All right, everyone. Welcome back to our webinar. And today we are so excited to have Marjorie Dixon with us today. And Marjorie came to us through so many different channels that all converged into us saying we just have to have her come speak to the community. Charlie was one of the first other PDE families that I actually met, and I know that you're his dietitian. And of course, the dietary guidance that you wrote with Curtis and the other PDE researchers is well known far beyond our individual connections. And I know that Marjorie is very busy, and so we're very lucky that she's joining us here today. And hopefully, we'll be able to get through as much content and questions and maybe some follow-up questions through email later if that's appropriate. I know that a lot of folks were with us yesterday, and so for those of you watching this recorded, hopefully it'll still be very beneficial, and I'll hand it over.
Thank you very much, and thank you for inviting me. It's a great pleasure to be here. I'm just sorry that it's taken me so long to get here. So you'll have to excuse me because I've got a little bit of a cough, so I hope it's going to be okay. So I am a metabolic dietitian, and I work at Great Ormond Street Children's Hospital in London, and I've been there for many years. And pyridoxine-dependent epilepsy is what I would say one of the newer disorders that we're looking after. But we can apply many of the principles that we do for other metabolic disorders to PDE. So today I'm calling it Exploring Restricted Lysine Diet for PDE, because not everything's known and you'll all be doing things just slightly differently, but following the same principles. Okay, so just a little bit about what we're going to talk about today. So the webinar content then, we'll think a little bit about the background of PDE, why we're wanting to do a lysine restricted diet, what's the rationale for that. We'll think a little bit about our international survey that I did with some colleagues in the field on dietary treatment, because we knew that people were attempting dietary treatment, but we didn't know how everybody was actually going about doing that. And that provided us with some really excellent information to then go on and formulate the guidelines. We'll have a little bit of a look at the PDE Consortium consensus documents, thinking about from 2011, 2014 and the 2021 publications, because they helped us again to think about our dietary management document. And then I'll take you through the process that we went through when formulating these, and how we derived where we got to really. We'll think a little bit about the practical aspects, but I'm not really going to dwell on that too much because I think that's where you're going to want to ask me questions. And I could tell you how we do this work at Great Ormond Street, but I think everybody's not going to be doing this the same. And this is quite reflective of what happens in metabolic disease and dietary treatment. It changes depending upon the part of the world you come from. And some of the terminology will be different as well. So some of the words that I use may not be similar to what you're familiar with. So I'll try and make sure that sometimes if I say something, that I will use the other words that I think people from around the world will use as well. But if you don't know what I'm saying, just shout out and say, what does that mean? Or else ask me in the questions at the end. So I'm hoping that we're going to maybe I'll talk for 25 minutes or so, and then you'll have plenty of time to ask your questions at the end. Okay, so let's just start with thinking about the long-term outcomes in PDE, because this is where this has all been driven from. And you'll all be familiar with the fact that despite we have adequate control of seizures with pyridoxine or vitamin B6, and early treatment, developmental outcome is reported to be poor. And I'm sure you're all very familiar with that. And we know that the later onset patients that present beyond the neonatal period tend to have better IQ. And there's many references on that I know are sitting on your Cure PDE website. So with any metabolic disorder, when you start to think about outcome, you often go back to the pathway and have a think about what's actually going on. what is it that might be causing a problem, and is there anything that we can actually do about that? And this is what was going back maybe around about 2010, 2011, people were beginning to think about what can we do to improve this? It's not just about the seizures, we want the children to do better. And we know that here's a defect in the pathway, and this is an enzyme that's actually in the pathway of lysine, in the lysine degradation pathway. Now, lysine is an essential amino acid, and we'll think about that a little bit more just shortly. So here it is. With any metabolic pathway, there's always several steps until you get to probably your enzyme. And we call this kind of upstream and we call this downstream. So here's a defect actually in our pathway. When you get a block in a pathway, what happens is that you can't go any further. It's blocked, or you can maybe get a little bit of going further. When you get a block in the pathway, things start to accumulate. This is a big word, but you're probably used to it being called AASA, so alpha aminoadipic semialdehyde. This is piperidine 6-carboxylate, P6C, which is in equilibrium with AASA. And here's your block again. And here's piperacolic acid, which accumulates as well. So here's the block, and here's things starting to accumulate. So lysine, one of your essential amino acids from protein, can be broken down via sort of two pathways. And so the thinking behind this was, can we reduce the load on the lysine pathway and reduce the accumulation of these things that were thought to be neurotoxic, potentially neurotoxic and causing a problem. And so there's going to be two ways that we're going to be able to do this. And as you know, what's happening here is here's our PLP, pyridoxine, and that's undergoing a reaction with P6C, and so making it unavailable. So PLP is your active form of vitamin B6, which you're all very familiar with because your children are having pyridoxine every day. So the idea is if we give less and less accumulates, can we help with the outcome? So the hypothesis, the working hypothesis, was that poor long-term outcome due to accumulation of these potentially neurotoxic metabolites formed in the lysine breakdown pathway, ASA, piperacolic acid, and P6C. So what can we do to help with this? So you're probably familiar with sort of adjunct therapies or lysine reduction therapies called LRT to lower the production and accumulation of these metabolites that we've seen that accumulate. So there's a lysine restricted diet, which I'm going to focus on, and the L-arginine supplementation. The terminology that's used to describe these is monotherapy, which is pyridoxine alone, double therapy, which is pyridoxine and lysine, or L-arginine supplementation, or some of your children may be on triple therapy, so that's pyridoxine plus the lysine restricted diet and plus arginine. So there's it's called mono, double, or triple therapies. So when we think about what we're doing, so with lysine, what we're doing is trying to reduce the substrate load on the lysine pathway. So if you've got less going through it, you've got less to sort of break down and hopefully less to accumulate. And then there's arginine supplementation. So how does this work? And then once we've had this slide on arginine, I'm just going to focus on the dietary side of things. So all amino acids have to be sort of transported in and out across cells, and lysine and arginine share the same amino acid transporter. So arginine competes with lysine for intestinal absorption and for going across the blood-brain barrier. So the thinking behind this, and this was all of Curtis's work really, so supplementation of L-arginine in large doses, so pharmacological doses, not just what you would have in your diet on a day-to-day basis. So in larger doses, would this help to reduce the uptake of lysine across the cell membranes? And the PDE Consortium Consensus Guidelines give some recommendations for that in neonates and infants, but no consensus could be reached for children and adolescents. And just to point out that arginine is not only it's not only just an amino acid in your protein foods, it's classified as a semi-essential amino acid, which means that the body does actually synthesize arginine. But many of your children may be on a protein substitute. Now that might be termed, we call it protein substitute, but you might call it medical food, you might call it synthetic protein, and you might call it L-amino acid supplement. So as long as you don't mind, because this is our UK terminology, I'm going to call it protein substitute. So that word is interchangeable. But your protein substitutes are enriched with arginine, but it won't equate to anything that you're doing with an arginine supplementation. So it gives some, but not in very high doses. So let's think about the lysine restricted diet then. So lysine restricted diets we've been using in another disorder, and I'm sure you've heard of this, called glutaric aciduria type 1. So we're very, very familiar with using with doing a restricted lysine diet. But what we've never done, or previously had never done, was in paradox-independent epilepsy. So it's slightly different. The enzyme's somewhere different in the pathway. And when we think about glutaric aciduria type 1, we also have to think about tryptophan, but we don't have to think about that in PDE. So the first studies were done by Clara Van Carnebeek, and I'm sure Curtis is in there as well, who looked at what we call an observational study, or a proof of concept study, where we're looking at, is this safe to do? Is this okay? So looked at 7 children with dietary lysine restriction, following the principles used in glutaric aciduria type 1. That's a safe thing to do because we were very sort of familiar with that. It was important to give lysine-free amino acid formulas. This is your protein substitute again. And the age of children that they studied started at 1 month to 11.8 years. And it's a median age of 3.6 years. So that means that most of the children were towards the younger age rather than the older age. And the time that they ranged on diet ranged from 6 months to 4 years. And the results of this study were that the diet was well tolerated with good compliance. There was no adverse events, so that means that there was nothing to worry about, no sort of deficiencies or concerns with the diet, so it was a safe thing to do. But one of the positive things, which is what the hypothesis was, is that there was a reduction in the biomarkers. So from there, that went on to produce this was published in 2014. So we're only talking about 10 years ago. So data's limited still, with a lysine restricted diet as adjunct therapy for PDE. And these were the consortium consensus recommendations. So at that time, we were also starting to look at our sort of patient group as well, and starting to think about dietary treatment. But one of the important things from that time as well was the formation of the International PDE Consortium, because people recognized that it was really important that as we were embarking on this, that we needed to provide more sort of evidence and patient information. And at the same time, the PDE Consortium was being formed, the PDE registry was being formed as well. And the PDE Consortium group was a multidisciplinary group of people representing sort of scientists, doctors, dietitians, the whole sort of metabolic team, neurology team that were involved in managing patients. And these were the first guidelines that were sort of published on management. And then more recently are the consensus guidelines for diagnosis and management of PDE. And I think, although we'd been busying away in the background with our patients, this was when I became much more involved. And I think lots of people, particularly in the metabolic dietitians community, were asking, how do you do the diet for PDE? What are you doing? Are you using protein substitutes? So there's lots and lots of questions from all parts of the world about what to do. And it was, I think, round about this time that we were asked to sort of think about the practical application of the lysine restricted diet. So the 2021 guideline has 30 statements in it related to sort of treatment. But there's very limited discussion on the practical application of the lysine restricted diet. And there was more and more evidence emerging to support the benefits of lysine restriction therapies, particularly if they were started early in life. So it seemed to be... So myself, Chloe Millington, who works with me, Laurie, who was working with Curtis at the time, Curtis, Morgan, Summer, who's working with Curtis as well, Clara van Carnebeek and Annemiek. So Clara and Annemiek, well, Annemiek's also a metabolic dietitian. She's from the Netherlands, set about thinking, well, how are we going to sort of update these guidelines that were produced in 2014? We were, sort of nearly 10 years on. So we felt that it was really important to undertake a questionnaire to evaluate current dietary practice. Something similar had been done by Laurie on glutaric aciduria type 1, and it was quite interesting to see the differences in practice. And we sort of started to model our questionnaire based on something that Laurie had done, but actually developed it to sort of much more detail, because we really wanted to understand this. And there was nothing published out there already about what were people actually doing, how were they interpreting these early guidelines that Clara and colleagues had published. So we developed our questionnaire. I'm going to share some of the findings. We looked at these consensus dietary recommendations. And we used the results of our questionnaire, and we looked at the statements from the 2021 guidelines on diet. We researched the literature, and we used our own experience, and we spoke to people about what they were doing to then be able to help us formulate our dietary management guidelines, which were published last year. So just to share a little bit more about that with you. So how did we go about doing this questionnaire? We did a SurveyMonkey questionnaire, which had closed and open-ended questions. And respondents were able to answer up to sort of about 42 questions. So it was quite demanding, but we know our dietetic community and everybody was keen. So we did get a vast amount of information, which was great. And actually, the results of that survey are published in the kind of the supplement or alongside our paper that we published. So if anybody's keen, you can go in and have a look at all of that information. So we asked people about treatment initiation, because we wanted to know, are you starting dietary treatment early, late, or are you not doing that? How do you calculate this diet? Are you giving these lysine-free protein substitutes? How are you interpreting the diet practically? What monitoring are you doing? Are you giving arginine? And are you giving an emergency regime, which is an illness plan? That's our terminology in the UK, emergency regimen, but I think you have sick day plans or illness plans. Those are other sort of words that are sort of used. Who did we contact? Well, we contacted the international metabolic dietitians groups around the world, and we collected our data back in 2021. I think we were in the COVID years, actually, when we were doing this. So that was quite interesting, but we managed. So I feel we did reasonably well, actually. We got 45 respondents, and that was only just one per centre. We eventually analysed 40 questionnaires, and 37 were from dietitians. And we had people from 13 countries allocated across 4 continents, predominantly North America and Europe, which I think would be expected, really. So, and in that collection, because we asked people about number of patients, now we didn't ask people for specific patient information. We asked them more about how do you do things, because we didn't want to have to apply for ethics, and we didn't ask for any patient confidential information. We just asked generally, how do you do things? So PDE patients, among that group, there was 155 patients, 146 children and 9 adults per centre, because of course patient numbers are generally small per centre. So it was 1 to 22 patients. The 22 patients was actually our centre, but we have increased on that now. And 6 centres had more than 8 patients. So people are looking after small numbers of patients, which makes it really difficult when you're out there on your own with a couple of patients thinking about, how do I do this? And that's the importance of guidelines to help people. And that was what we were trying to do.
Marjorie, can I ask you a question? Your center has 22 PDE patients?
We've actually got more than that.
Wow.
Mm.
Local or driving in from all over?
Some are north of England, but round and about.
Wow. Okay.
So it's not central London. They do come from the home counties and
Sure, sure,
slightly
sure, sure.
further afield. But yeah.
Interesting. Very cool. Thank you.
But the neurology, because they used to be primarily under neurology, but when we started doing dietary treatment, they started to be focused under metabolic. Mhm. So in that sort of patient group, 107 of the patients were on diet, and 87 of those were on a lysine-free protein substitute. So let's just have a look at that in a little bit more detail. So you remember we've spoken about mono, double, or triple therapy. So we did ask people, what are you doing? Are you doing triple therapy? Are you doing double therapy, or are you just doing pyridoxine? So you can see that most patients were on triple therapy, or they were on double, and the double could either be pyridoxine and diet or pyridoxine and arginine. But some patients were just on pyridoxine. And I imagine that these are patients that are older patients. And we do have some of that data, but I just haven't brought that today. So this is what was sort of happening. So then what we did as part of the questionnaire, we took some of the statements from the consortium guidelines, and we asked people sort of questions related to that to see if people were actually doing that. So one of our questions, and I can't go through all the questions, there are way too many and you get really fed up. So all newborns and infants with PDE should be treated with lysine reduction therapies. So we asked the question, in infants under 12 months of age, what treatment do you routinely give in addition to pyridoxine once diagnosis of PDE is confirmed? So you can see there's a bit of a mixture. So lysine restricted diet with the protein substitute, lysine restricted diet and arginine, and then most people are doing the sort of the triple therapy. So people are doing this from a young age. I'm not sure what the other was, but we did get lots of answers from people. And then we asked, so these are the statements 16 and 20 and 17 from consortium guidelines. So we wondered what was going on with infants, but then we also wondered what was going on with children. And this is, are people putting children with PDE that are older onto dietary treatment? We wanted to try and sort of understand that. Because the consortium guideline recommends that if there's delay, difficulty, poor seizure control should be treated with lysine reduction therapies. And in children and adolescents, a lysine-restricted diet may include a lysine-free formula protein substitute, but if not well tolerated, then you can do a lysine-restricted diet without. So what were people doing? And I've kind of summarized this because it looks a bit messy when you do it as a graph, really. So we said, have you initiated lysine-restricted diet with or without protein substitute in children over a year? And what we found is that younger patients were more likely to have a lysine-restricted diet and protein substitute than older patients, which I think was to be expected. Older patients were more likely to have L-arginine supplementation. It's much easier than a diet. 56% found it difficult to introduce a protein substitute at over a year of age, but mostly with teenagers due to sort of, it's quite a bitter taste, isn't it? Taste aversion. However, I think this was quite telling actually. In all of the patients who were started on dietary treatment, only 10 had discontinued due to issues with sort of coping with the diet. So despite the fact that people have said that it was difficult to institute treatment, people have remained on treatment. And it'd be interesting to repeat this now because maybe more. There's the initial excitement, isn't there, about starting dietary treatment, and then with time it becomes more difficult. 97% were using protein substitutes that were suited for glutaric aciduria type 1 because there's very few of these protein substitutes that are PDE specific products. And so how do they differ? So the protein substitutes for GA1 are free of lysine, but they're also low in tryptophan. So you can use them, of course you can, but ideally we could do with some more PDE specific products that have tryptophan, that contain tryptophan, because we don't need to restrict it. And most people were recommending giving protein substitute 2 to 3 times a day. And then we asked them, how do you calculate the daily protein lysine intake? Because we knew that people were doing all sorts of different things. And this was one of our big purposes of our guideline was, can we help people to do this? And can we all be doing the same thing so we can make some comparisons of treatment? So most people were using the PDE consortium guidelines, but interestingly, 37% were doing the GA guideline. Now, this doesn't add up to 100, by the way, for those of you that are doing your maths, because people were doing different things. And so we allowed people to give multiple answers. So when you see things and you think, oh, this is more than 100%, that's just because we allowed people to say more than one thing. So there was a bit of a blend going on here of what were people doing, and you think, oh, why were they using the GA1 guideline? And then we said, well, how are you doing this? Are you doing a combination of lysine and protein only, or lysine only? And the consensus recommends that the diet's based on lysine restriction rather than protein only, but hardly anybody was doing that. So it's a bit of alarm bells, isn't it? Because you think, obviously, doing lysine is difficult. So can we make it easier for people? And is there a way to do that? And I'll explain why that becomes important. So most respondents also didn't aim for a certain proportion of protein to come from high biological value protein foods. And again, that will just become clearer in a moment why that's important. So with any dietary treatment, it's so important to monitor what you're doing. So all patients were treated with, the statement says, all patients treated with a lysine-restricted diet should have plasma amino acids measured at least every 3 months in our under threes, and every 6 months above 3 years of age. And all patients on lysine reduction therapy should have plasma and urine biomarkers, the P60, and or ASA measured every 6 to 12 months to assess for treatment efficacy. So we asked people, well, what do you do? So this is what people told us. So they monitor lysine. Most people do that. A lot of people monitor tryptophan as well, despite the fact that it's difficult to monitor. And they'll monitor other amino acids. So I think if people are monitoring lysine, I feel fairly certain they'll be doing all amino acids, because when you do one, you used to tend to do them all in the laboratory. People were measuring things like urine and plasma ASA and P6C. And what we've done is that we've combined these together. So if they were doing either or, but you can see that not everybody's doing that as part of their monitoring. And that's because these are quite difficult to monitor and probably only monitored in specialised laboratories. The other thing that we were particularly interested in was vitamins and minerals, because any restricted diet, you're at risk of nutritional deficiencies, and vitamins and minerals will be one of them. The minute you start to restrict protein, you start to restrict all sorts of things in the diet. We also asked people what plasma lysine concentration do you aim for? Most people said the normal reference range, and 50% said the lower reference range. And the recommendation is that the consensus recommends the lower quartile of the normal reference range. So reference ranges, they're going to be different in different laboratories. So for example, in our laboratory, it's 100 to 300. Some laboratories have age-specific reference ranges as well. Ours is just the same, but if I went to another laboratory in the UK, you would probably find slightly different reference ranges, and they might have age-specific reference ranges as well. So it's quite hard when you start to compare things like this and roll out numbers and say, oh, mine are 150. But if somebody else has got a different reference range, it's difficult to compare. So what we try to do is to keep our reference range is 100 to 300. We try to keep ours around about 100. But sometimes it's below, sometimes it's above. So what next? Yes, we wanted to ask people, do they teach this emergency regime, this sick day plan, illness plan? Because we know that illnesses that have fever, you might have a seizure relapse at that time. And that's something we always ask our families. Have they had an intercurrent illness? Did they have a temperature? And did the child have a seizure? So the advice from the consortium guideline is you can double dose pyridoxine up to certain maximums for up to 3 days. And in times of illness, it's important to ensure an adequate calorie intake to prevent catabolism. So when you're not eating, what the body does is it starts to sort of use its alternative energy stores like glycogen and fat, but you also start to break down protein. And when you break down protein, lysine is going to be broken down as well, and that will put a bit of extra stress on the pathway. So if you give energy, calories as glucose, then that should help to prevent breakdown protein. So it was important for us to understand, are people actually doing that, and do we feel that it's necessary? So about 42% of people said no, they're not. 30% said yes, sometimes, and then people didn't answer. We didn't always get answers for all questions, so I'm only giving you percentages out of the total number of answers that we had, but it still gives us a clear idea of what was going on. So there you go. We've got all of our, well, there's a lot more questionnaire results, but I picked out a few that I thought you'd be interested in. So next, what we did is that we embarked on thinking about our results, going back to the consortium guidelines to look at the statements about diet. And when we wrote our document, this is how we did it. We discussed the questionnaire results first. We looked at the statement and we stated the statement in the guideline. Then we discussed it, and we discussed it around trying to give some clinical practical experience. And that was based upon kind of what we were doing and what we'd found from the survey. Then we made our recommendations, and then we tried to give some practical examples of how to do it. I think it's really important to be aware that a lot of these recommendations are based on what we call expert opinion. So there's not a lot of sort of published data to sort of back up what we're saying, but more and more is being published, and we're hopefully just going to be publishing something from our own centre in the next couple of months or so about our sort of patient outcomes. So this is this is just taking you through. These are some of the headings. So this is called lysine restriction diet, and this is our recommendation. So lysine is an essential amino acid. So that means it needs to be provided in the diet. You can't make it, you have to give it. But the thing about lysine is that amino acids in food, their content varies, but for lysine, it's particularly different in that what we call high protein foods, the way to look at it is per gram of protein. So in high protein foods, you have a lot more lysine per gram of protein compared to lower protein foods. So these high protein foods are called high biological value protein foods, and these ones are called low biological value protein foods. So these are the things like meat, fish, and dairy, very high in protein. And 1 gram of protein is from a tiny amount of food. So 1 gram of protein is only from 6 grams of fish, which is tiny. So, a spoonful, maybe not even a spoonful. Whereas in the lower protein, so when you look at the high protein foods, the milligrams of lysine per gram of protein ranges from 60 up to about 90, maybe even 100. And then for the lower protein foods, like cereals, potatoes, rice, bread, pasta, the amount of lysine per gram of protein is much lower and can range from about 30 up to 60. However, the portion size of the food that you get is much greater. And this sort of kind of forms our thinking about how you give lysine in the diet. Because if you give all of your lysine from these lower protein foods, you're actually at risk of lysine deficiency because it's so low. Whereas if you gave it all from high protein foods, you wouldn't get very much food at all. So what we're recommending is a blend of some of the high protein and some of the low protein to ensure that you get enough. So we've said the lysine content varies. The other thing to also let you into is that there isn't much analysis of lysine. There's a real sort of lack of information in the UK. It's very old, and we tend to go for the information that's from Germany, because their analysis is a bit more up to date, or else from Metabolic Pro in the UK. So for accuracy of our lysine restricted diet, it's recommended to count or estimate the lysine content of foods to ensure adequate intake and reduce the daily variability. So let's think how we're going to do this. So this is the job of the dietitian. So as families, you don't need to think about this. So how do we teach this practically? So the dietitian will calculate the daily lysine requirement and then equate it to a daily protein intake. So you can look at food and say how much protein is in this, because you can't pick up a food and see the amount of lysine in it. It's not there. And so I think probably many of you are totting up the amount of lysine just using sort of food tables and things like that. But our approach is to actually do it based on a daily protein intake. So we will turn the lysine recommendation into a daily protein intake, and we'll count it as sort of daily protein exchanges. So you're given a set amount of food from protein exchanges to have every day. And we advise giving some as from this high protein list up here, and then a lot from the lower protein list down there. So it's important to ensure an adequate daily protein and lysine intake, because, as I said, if you give it all from the lower lysine foods, you're at risk of lysine deficiency. So we tend to sort of give a combination of high protein and low protein. And this sort of ratio makes sure that you have enough natural protein in the diet on a daily basis. Might sound complicated, and I'm sure you're going to share how you do it at your centre, but this is to try and make it practical and easy, so that families didn't have to be counting up little figures and not being able to pick up a food and look at the amount of protein that's in it and think, oh, how much protein is this and how much lysine is this? So we're counting daily lysine intake, but we're doing it through using protein.
On
Complicated, I
the
know.
last slide, what does it mean that it's limiting amino acid in cereals?
Okay, let's just go back to that one. So when you look at the amino acid content of cereals, they have all sorts of different amino acids in them, but lysine is the one that's in the smallest amount. So if you had to eat the same food to get all of your amino acids, then the thing that you would have to eat, you'd have to eat more and more of that food to get you the lysine that you needed. So it's limiting. It's there in low amounts, and that's why you would have to eat a large amount of cereal-based foods to get all your lysine, which is why we make a recommendation to give some of the higher lysine foods to ensure that you don't have that you don't become lysine deficient. It's quite easy to actually go to quite a low lysine intake. Um, then how much protein substitute do we give? This is our medical food, all that terminology. So on lysine restricted diet, just looking at the time, the protein substitutes, we've sort of done similar to what's been done in GA1, because this was very difficult to think about this, and we used a lot of our knowledge around other disorders that have protein substitutes, and decided that we wanted to make this a recommendation definitely for infants and young children, but for older children, so that we're in line with what the consortium guidelines says, is that we can still do our diet safely using our sort of what I've just described. But for infants and children, we're giving extra protein. So we're meeting a safe protein intake for growth, but we're giving more because infants and children at a young age grow very rapidly. So we're topping up the diet by giving more protein substitute and making it similar to some of the other disorders that we look after. So we're recommending about 1 gram per kilogram per day. So that's quite sort of a modest amount. And to divide that over 3 meals, because if you think about the protein substitute is like the meat part of the meal, the fish part of the meal. So you wouldn't eat it separately or give it separately. You would eat all of these things together. So that's why that's recommended. If you're not having a protein substitute, then very, very important to give a micronutrient supplement. Because on these restricted diets, if you're not getting a lot of sort of the higher protein foods, which we're not, then you start to run into deficiencies quite quickly with things like B12 and iron and calcium. So very important to give a micronutrient supplement. Biochemical monitoring is very important. So how do we monitor diet? Any metabolic diet must be monitored. So we look at things like plasma amino acids, which measures lysine. And as we said, we're aiming for the lower quartile of the normal reference range. It's actually quite easy to get it below the lower normal reference range. So if it's low and persistently low, we would increase the protein intake or look at how the protein's being provided in the diet. Do we need to alter that ratio? We do look at plasma, we look at urine ASA, which decreases with age but remains above the upper limit of normal, and you can get some fluctuation. So it's important to continue to monitor this because we want to make sure that it's not rising, and it's a way to make sure that we've got the diet right, but we wouldn't make alterations based on this because there's no therapeutic target or ideal reference range for this. So we base most of, or really all of our sort of monitoring of the diet on plasma lysine, and growth is important. We also monitor things like vitamin and mineral status as well, which is what we're seeing here, because you do have risk of deficiency, particularly of things like B12 and iron. So we would be monitoring these every 6 sort of months or so. So really just my sort of final slide is just thinking about illness management. So in the guideline, we have actually given some guidance on how do you manage illness. We've already spoken about that you can increase pyridoxine. We make the recommendation to continue the protein substitute because that's important for protein synthesis and to maybe help prevent catabolism. So how do we do this? Well, we make recommendations of giving a glucose polymer solution. So this is a high energy drinks to try and keep the child hydrated, particularly if there's fever, but also to give lots of energy to prevent catabolism. If they're on a restricted lysine diet, there's no need to formally omit all the natural protein, but as you know, during illness, a reduced appetite always arises, so protein intake is reduced. So the main aim is, if you're not eating well, give lots of the high carbohydrate drinks to help with catabolism. Continue any L-arginine supplementation and certainly treat high temperatures. So I hope I've been able to share with you that we've reviewed and updated the 2014 diet guidelines and tried to provide some practical recommendations along with that. If you're very keen, do go to the paper because there's lots of reading to be done in there and it explains more about the questionnaire and what we've done. Experience is still very limited with the diets as these recommendations are highly dependent on expert opinion. Future research is essential to increase our knowledge about the individual added value of lysine-restricted diet and arginine supplementation. We need to find new biomarkers to assess the effectiveness of these. And what we wanted to think about once we'd written these guidelines is we want to understand the role of protein substitute more. Do we need to give it? Can we give less? And we certainly need some that are PDE specific. And it's important to explore the use of emergency regimes. What is their role? Have we got that right? So I am going to end there and come over to you.
Thank you so much. Guys, this is 10 minutes for questions, so feel free to pop in. See some new people. Hey guys, thanks for being around. Feel free to ask Marjorie any questions.
Well, maybe I can ask you questions then. Is what I was talking about, does that feel familiar to you? Are you doing something different? How have you, do you have an easy way of doing the diet?
Question. My daughter is late onset. She's had her first seizure at 17 months. And we currently work with Texas Children's, their metabolic department there to like manage her diet. We're doing the triple therapy. So she's on pyridoxine and Keppra, L-arginine, and she's on a protein supplement. We were having trouble finding one that she would tolerate because of taste, but we have recently found one that she is tolerating better. But when we repeated her labs, her pycolic acid had gone up. And we touched base with our neurologist, and they were saying that it was of no concern because it's still within the normal range. But I just found it odd that the pycolic acid would go up with implementing the diet. Do you see that?
Is that plasma or urine? Do you know?
This last one was plasma.
Okay. So I think anything that you measure will always fluctuate up and down, and nothing is stable. And the fact that you said that it was in the normal reference range, I wouldn't relate it to. I wouldn't be worried about that.
Okay.
Yeah.
And then some days she will take the supplement better than other days, and sometimes it worries me if she's getting more one day and then the next day she doesn't. Does that mess up the flow of any of the channels? Just on the days we can get it as much in as we can, great. And on the other days, we do the best.
I wouldn't think it shouldn't do, because you've got your lysine restricted diet, and that's the important thing. What I would say is it depends upon how restricted the lysine intake is. So it's and so that's difficult for me to answer, really. So that would be a discussion to have with your team, because if her lysine intake is sort of below a certain level and she's not having what we call the protein substitute, then that may be of a concern. But go back to your team and just check out
Okay.
with them, if that's important. And then also just maybe think about, can she have an overall lower dose, or is she having a lot? So is there any flexibility within that really? But I do agree that the choice of supplements is very limited.
Yes. Well, thank you so much. I appreciate it.
That's okay. And starting at 17 months is hard as well.
Yes.
Start small and increase. And I would say that our families are quite creative in what they do. So they mix it into things that have got quite strong flavors, or they might mix it into, even, I think yogurt is quite a popular thing to mix it into. So we've got some yogurts that are very low in protein in the UK. So that tends to be something that's quite good.
Okay, great.
As well. So yeah, and I think we've probably listed some of the things that we mix them in on our guidelines, so you can maybe have a little look.
Okay, thank you so much.
No problem.
Hi, I'd like to ask a question regarding the supplementation with the vitamin B6. What's the difference between pyridoxine and the active form of the vitamin? Because I have come across over the last 1 year of very conflicting information for the neurotoxicity of high dosage of pyridoxine. And more people are recommending using the active form of the vitamin instead of the artificial one, which is the pyridoxine. Could you please explain the difference? And do you really think using the active form as supplementation is more beneficial for the children?
Okay, so I'm going to ask Curtis to answer that for me, because that's the medical side and that's pharmacological doses. So I'm going to stick with diet, but I know Curtis is there. Thank you.
Yeah. So first, I want to make sure that we're talking about pyridoxine-dependent epilepsy due to mutations in ALDH7A1.
Yes, that's
Okay.
our.
Because I know there's other families who join who have other pyridoxine-responsive seizures, and that is a different story, and I'm also happy to talk to those families. Paradoxal phosphate, the active form, is actually much more worrisome. Actually, Marjorie's group in London has done a lot of really great work. Some researchers named Peter Clayton and Philippa Mills around the fact that that vitamin can give you liver disease, or something we call liver cirrhosis, and can also give you liver cancer, a specific cancer called hepatic cellular carcinoma. And so we're worried about giving high dose paradoxal phosphate. And lots of smart people are trying to come up with actually new versions of paradoxal phosphate, including Marjorie's colleagues. And so the reason we give paradoxine is that the risk of it is fairly low. It's at very, very high doses. So I don't know what dose you or your children are on. I'm happy to learn more about that. But if you go too high, you can get a little bit of nerve changes, neuropathy, that goes away as soon as we give a lower dose. And so the risk is small. There's a lot more room to give it. And if we accidentally give too much, it's reversible, whereas all the things with paradoxal phosphate aren't. So happy to talk more about that in general with you. If you want to email the Cure PDE group, they can certainly pass my contact information along. I hope that, or Christy in my lab can put her contact information in as well.
Okay, yeah, we are actually on a very high dosage at the moment, 200 milligrams in the morning and 200 milligrams in the evening, which is kind of approaching the maximum.
So we recommend 500 milligrams as a max because the risk of neuropathy is actually at 1,000 milligrams, and most patients need less than 500. So we just want to keep a buffer. But again, happy to talk more about it. And Christy in my lab's email is in there as well as the Cure PDE. So email both of them or one of them or everyone. Happy to talk more. But I'm not no one has ever had symptoms at 500. That's why we said that's the max.
Okay, thank
All
you.
right, Marjorie, let's get back to Marjorie's expertise.
All right, Rebecca.
Yeah, so everything that I was talking about is it is for PDE as Curtis described, really. So I'm not talking about other disorders. I can, don't worry, I can stay for another 10 minutes or
Oh,
so.
you can.
If you like, so don't worry.
Okay.
Hi, yeah, just a quick one. So my little one, she's really struggling with swallowing. We're in contact with obviously speech and language. Yeah. So my question is, at the moment they want to try acid reflux, which I don't think it is because, but you know, well, obviously I've heard about different thicknesses because she coughs a lot when swallowing with water, with different bottles, different types of bottles. Now, I'm just worried that the thickening sachets that they would use, would it be like gelatin and stuff? Would it have protein in it, or is there a form of something to thicken her juices up without going down that route? Because I don't want to take that away from her protein intake.
Yeah, definitely. I mean, there are different thickeners on the market, and most of them are starch based because they're thickeners, so they're starch based. So it's unlikely that and you could ask specifically to your speech and language therapist, can we just make sure that the thickener doesn't have any protein in it? But generally, certainly, are you from the UK?
Yeah, we're under the Evelina. Yeah, we're under
Yeah,
Evelina.
I was sort of thinking that's a UK accent for sure.
Yeah,
Yeah, just ask the dietitians. That'll
yeah,
be fun. I know
yeah,
them quite well. They'll guide you. Don't worry
yeah.
about that.
They're amazing. They're an amazing team.
Yeah,
Thank you.
no problem.
I think Becky was next.
I just have a question if there seems to be a difference between animal-based protein and like vegetarian protein and the amount of lysine, because just we're still kind of new to the game. My daughter just turned 1, but just listening to other parents, it's a lot of you know, like avocado and things like that. And I just wonder if there's a difference in lysine levels between animal and plant-based.
Yes, definitely. So how we think about it is the amount of lysine per gram of protein. And so for things like meat and fish, if you look at how much lysine there will be per gram of protein, it's the easy way to think about it. It's things like, it ranges from about 70 to 100 milligrams of lysine per gram of protein. Whereas your plant-based protein, which, well, apart from legumes sits in that higher protein. But if you're thinking about, when you think about plant-based, are you thinking about cereals? So things like rice, potatoes, pasta, are you thinking about vegetables?
A little bit of both. So either like oatmeal, rice, or, you know, like we've been introducing different vegetables into our diet.
Yeah. So they're definitely much lower. So we said for the higher ones between 70 and 100, but for the lower ones around about between 30 and 40 milligrams per gram of protein. So that's why we sort of split into two really, and advise giving a small portion of the high protein, but more of the lower protein. So if you are giving all as low protein, the cereal based foods, then you just need to be cautious that you're getting enough. But I think one of the greatest difficulties is the lack of information about the lysine content of foods. So that's why we sort of transcribe it into sort of being protein, just to make it practical and easy. But Christy's joined, and I think it would be nice to ask her what you do, if you count lysine or protein, and how you get around it. Christy works with Curtis, so I thought that might be a nice idea.
Yes, we do. I think Curtis does it more along the lines of, actually he defers to what the dietitian of each group does. So he doesn't want to override the team's method of
Yeah, exactly.
addressing it. So yeah, we kind of shy away from that, to be honest.
Yeah, yeah. I think it's right because, you know, with any dietary treatment, your interpretation of how to do it is, first of all, maybe how your centre does it, but you need to work with a family, and that's so, so important. What can they manage, and what's practical? Because you're only going to succeed if you can do that in a practical, easy way, and not make it difficult.
Yeah.
Yeah, and I think I wouldn't get too worried about lysine content of foods because we just don't have a lot of good data.
Yeah. I know there's been a question that's come up several times with families as far as lysine content, like an app that calculates lysine
Oh
content.
yes,
Do you,
yes,
I know
Metapod
some,
Cat, yeah.
yeah. Are there ones that you recommend for that, or do you also think that they're not, from what I understand, they're not great? So most dietitians don't necessarily recommend them.
So we count protein. We calculate out how much lysine, and then we equate that to the amount of protein.
Yeah.
So that's how we do it. So say it's 800 milligrams of lysine, then we'd relate that to a set amount of protein in the day, and do it that way. Because yeah, too difficult otherwise, way too difficult. But I think it's just that awareness of the different lysine content of foods is just quite important.
Gotcha. I think there's a question in the box. Let's see.
I'm just trying to have a bit of a look if I can see. I have to work today. Try. Is there any proof that the diet and arginine can have beneficial results that have started it later? I think the answer to that is no at the moment. Is it possible not having low ASA values, although following LRD and arginine? This happens, shows that we have to be more strict regarding diet. So these are quite difficult to answer without having the things like the values really.
Yeah.
And I think I have to refer people back to their own teams because I can't really comment on other sort of people's management. I can give general advice, but I can't be specific. So yeah, 2 meetings have to work. Let's see if I can.
One more question when there's a second.
Carry on, because I'll just be reading down the
Okay.
questions.
I guess other families in the chat who have kids with PDE, have you seen a significant change in your child? You know, I guess if you have older children from once you've started the diet to previously not being on the triple therapy?
Could say I think we definitely noticed a difference in her milestones and everything after starting triple therapy.
It's difficult, isn't it? Because children develop, and what would be normal development and what wouldn't. It's a really difficult thing to assess, really. And we are very early into all of this, really. You know, it's sort of 10 years, and not everybody's been on dietary treatment for 10 years. And so the natural history of what we're actually doing isn't, we don't really know quite so much at the moment. In the years to come, we'll know a little bit more.
Thank you.
I think
Question for you as
or the database. Find an accurate data. Victor said, best database to count lysine, find an accurate data to avoid get wrong with the intake is very difficult. Not 100% sure what that means, but Yeah. You next for a question. Did Becky ask me a question? She did, didn't she? Okay. On the guide is protein intake based off the percentage of weight. So that was for Steve. So the percentage of the 70 to 30. So what you do to start with is that you calculate the amount of lysine based on body weight, but you need to take into account, is that child of a normal body weight for their height? So you do calculate it off body weight, and then when you have the amount of protein that you want to give, then that's how you do the percentage. So the percentage is not calculated on body weight, if that answers your question, Steve. I can see Steve in the audience, but he's not put his on. Does anybody have any other questions?
A question. My camera's not working for some reason. It was about arginine. My daughter has always taken the arginine hydrochloride. And we found out that a lot of other people in the PDE group take the arginine base. And her doctor did say that they are the same thing. And he actually told us to continue with the hydrochloride as it's better absorbed for her. I was just wondering if you could confirm this.
I don't have that knowledge, I'm afraid, about the absorption. I think if you really want to know about absorption, you have to go back to your medical team, because pharmacies understand what, pharmacokinetics, so they understand about absorption. And so that's where that information would come from. And so maybe your team has actually looked into that for you. Because often, yeah, when things are done with sort of medicines, then yeah, that's important to do.
I was just wondering if it mattered, should she be taking one or the other for what she has?
Yeah, I don't know the answer to that question. Honestly, I think best just go back, and if you've been told that, then yeah, maybe that's something we could ask Curtis, Christy. He
Thank
might
you
know
so
the
much.
difference between the different types of arginine, because I know he's done a lot of work on arginine.
Yeah, I can ask him that. And then Leslie, I'm not sure if you want to DM me your email address. I can just email you directly.
Yeah.
Any other
I think there was one more question, and I think it's kind of the same one that you may have answered already. Victor was asking the best tool to check lysine levels in foods, but yeah.
Yeah, I mean, as I say, Victor, we use protein. We count protein rather than lysine directly for that very reason, that we have very limited amount of information on the lysine content of foods, and it also makes it quite complex to count lysine. So I think we go with protein from a simplistic point of view. There are a few databases out there. I don't know what access do people have in the US to look at the dietitians' databases. I mean, they're so complicated, aren't they? And how do you interpret them? And do you really want to be adding up lots of different figures every day? You have to sort of try and make it practical for yourself and easy.
Definitely. Well, Marjorie, I don't want to keep you. I know you have something that you have to head out to. Thank you so much. This was great. I think it was wonderful that you were able to break it all down and kind of spell it out very simply for all of us. So we appreciate you taking the time to do that. And I know Anna said that she may send you some other questions if that's okay, if she gets other.
Yeah, that's okay. Yeah.
Okay.
I just have to be very careful about what I'm answering because you're all looked after
Right.
by different people. So, you know, it's difficult to answer. Well, I can't really answer sort of child-specific questions, but I can answer general
Yes.
questions.
Perfect.
Thanks
So if
so
anyone
much,
has any
everyone.
questions, just thank you so much.
My pleasure. Bye-bye.
Thank
Bye-bye.
you.
Bye. Bye.
If anyone has any questions, you can go ahead and email Anna or even me, and I can get them to Marjorie. Thank you all for attending.